Hello everybody. This is Dr. Kapil Gangwal from Jaipur. Going to be reviewing the literature on complications of lateral humeral condyle fractures in children today. Going to be looking at 10 articles of importance pertaining to this area, and let's get to reviewing the articles right away. So the first one is the study on pediatric lateral condyle fractures, which is a systematic review of these fractures. The study was conducted at the National University Hospital at Singapore, and the article was published in the Archives of Orthopaedic and Trauma Surgery in 2018. The study was designed to assess risks of developing complications in this group of patients. And 445 studies with 2,440 patients were looked into. The review was conducted in accordance with the PRISMA guidelines. While specific complications resulting in the management and diagnosis of lateral condyle humeral fractures have been enumerated in the study, along with the risk of developing these complications. And the review also draws an association and risk of developing complications with regards to the fracture classification and pattern, fixation methods, misdiagnosis, and management of these injuries. Recommendations with regard to management have also been given on the review of various studies included in the systematic review. This is the most current and the largest review covering the complications pertaining to lateral condyle humeral fractures in children. While coming to the second study, which is the pediatric lateral humeral condyle fractures outcome at 12 years follow-up as compared with age and sex match pair controls. Well, this is the first follow-up study of lateral condyle fractures in children with the average follow-up of 12.4 years. It was published in International Orthopaedics in 2017. Clinical and functional results were compared with age and sex matched normal controls. Well, 32 children participated in this study, and the children were assessed according to the Flynn's criteria, which takes into account elbow range of motion, which is also termed as the functional score, and the varus valgus deviations, which is termed as the cosmetic score. In addition, the Mayo Elbow Performance System was used to assess pain, motion stability, and function. Radiographic outcome variables were assessed for deformity and degenerative changes. But unsatisfactory outcomes were found in 40.6% of the fracture cases compared to 6.3% in the control group. Range of motion was reduced in 40.6% in the fracture cases compared to 12.5% in the control group. 25% of the cases had cubitus varus and 15% had cubitus valgus deformities compared to 3% cubitus valgus in the control group. Early surgery showed better outcomes, and late presenting cases had worse outcomes. Fracture displacement did not correlate with outcomes based on Flynn's criteria, and all patients and controls achieved a satisfactory MBPS score. While pain was the most common long-term symptom in 25% cases, this was constant in 25% and occasional in the other 75%. 6 patients had lateral overgrowth, 6 had loose bodies, and 5 had joint space reduction more than 2 millimeters. Significant number of children had elbow range of motion restriction. This, however, was not significant to cause functional impairments. Cubitus varus and valgus deviations did not show any remodeling over the years, and lateral spur also did not show any remodeling over time, though it did not cause any functional limitations. Well, the third study is a new classification system which was predictive of complications in surgically treated pediatric humeral lateral condyle fractures. It was a retrospective study of children with lateral humeral condyle fractures from the Children's Orthopaedic Center at the Children's Hospital in Los Angeles, USA. All type 2 fractures with displacement more than 2 millimeters with intact articular cartilage, and type 3 fractures with displacement more than 2 millimeters where articular cartilage was not intact were studied for complications following treatment. Children were studied according to age, duration from injury to surgery, and duration of casting. They were all 25% complications. The most common complication was a lateral bump, seen in 10%, infection was seen in 2.5%, malunion in 3%, non-union in 0.6%, and range of motion limitation was seen in 17% cases. 13 of the 19 patients with complications had a type 3 fracture. 11% of the type 2 fractures had complications, while 34% of the type 3 fractures had complications. The complications were further subclassified as major, which required a secondary intervention or which had long-term sequels, and minor complications. 9 of the 10 major complications occurred in the type 3 fracture group, and 23 of the 29 minor complications were seen in the type 3 fracture group. In retrospective analysis, all type 2 fractures had an articular step-off of less than 4 millimeter, and the type 3 fractures had an articular step-off of more than 4 millimeter, making these at higher risk for complications. While the fourth study is comparison of Kirschner wires and AO cannulated screws for internal fixation of displaced lateral humeral condyle fractures in children. It's a retrospective study comparing these two modalities of treatment, and the study was conducted at the Department of Pediatric Orthopedic Surgery at the Chinese People's Liberation Army General Hospital in Beijing in China. 62 patients were included in the study. All children had an open reduction. 30 patients had K-wire fixation and 32 had a screw fixation. Average fracture displacement was 5 and 6 millimeters respectively and was comparable in the two groups. Mean follow-up was 39.4 months. 5 patients, which is 16.7%, had irritation around K-wires, while there were no infections seen in the screw group. 11 patients had lateral condylar prominence, which was in the K-wire group, compared to 4 in the screw group. 2 children in the screw group, which is 6.3%, had 10% restriction of range of motion compared to the normal side, and 7 patients with K-wires had significant difference in their carrying angles compared to 6 in the screw fixation group. Displaced fractures can be treated. Some important conclusions drawn from this study are that displaced fractures can be treated successfully by open reduction, either with K-wires or screws with excellent results. And the K-wires or screws should be removed only when there is evidence of fractured union on follow-up radiographs. K-wires can be safely passed through the ossific nucleus of capitulum without damaging it. Percutaneous K-wires have advantage of easy removal at the price of increasing the possibility of skin infection and K-wire loosening. And screws may have a potential negative effect on the ossific nucleus of capitulum, though it was not documented. And a second operation is needed often for screw removal. Screws could reduce the possibility of lateral prominence and promote union of fracture by continuously stabilizing the displacement of the fracture. While the fifth study is looking at deformity after fracture of the lateral humeral condyle in children, and the authors are Skak and Olsen. It was published in Journal of Pediatric Orthopaedics B in 2001. And it comes out of the Scandinavian countries, Denmark and Norway. 28 lateral condyle humeral fractures in children were studied at an average of 6.3 years after the fracture. There were only 2 Milch type 1 fractures in this group, and all children showed a widening of the lower end of the humerus during follow-up. 6 had varus deformity and 4 had valgus deformity. There was a deepening of the trochlear groove, which was seen in about 96.3% of the Milch type 2 fractures. There was AVN in 1 child, and the authors concluded that deepening of the trochlear groove, described as the fishtail deformity, was a constant finding in the Milch type 2 fracture group. While the next study looks at the rate and risk factors of delayed healing following surgical treatment in lateral humeral condyle fractures in children. The study was published in Journal of Pediatric Orthopaedics in 2015. It's a retrospective study and comes out of Rady Children's Hospital and Health Center in San Diego, California, in the United States of America. The purpose of the study was to evaluate the rate of delayed healing of pediatric lateral humeral condyle fractures after surgical fixation and to identify risk factors for delayed healing. A total of 210 children were evaluated. Operative data evaluated fracture classification based on the Weiss classification and also included surgery time, fluoroscopy time, and the surgeon's experience. Delayed healing was defined as those fractures that had not healed by 8 weeks from injury. The mean follow-up was 25 weeks. There were 33 delayed unions, and 7 of these required further surgery to achieve healing. Patients with more than 1 millimeter displacement of the lateral cortex after fixation at an increased risk of developing delayed healing. The risk of delayed union also correlated with operative and fluoroscopy time in surgery, with higher risk being associated with increased use of image intensifier during surgery, and this probably correlated with more displaced and difficult fracture reductions. Well, the next study we're looking at is long-standing non-union of fractures of the lateral humeral condyle. The study was conducted at the Department of Orthopaedic Surgery at Hirosaki University School of Medicine from Japan. The purpose of the study was to evaluate long-standing established non-union of the lateral humeral condyle in order to clarify the long-term clinical outcome of this condition and to identify factors contributing to the results. The 19 elbows in 18 patients who were at least 20 years of age were evaluated. Average age at presentation was 42.5 years. The average interval from injury to presentation of the symptoms of the non-union was 37 years. The patients were divided into two groups based on the size of the fragment and the location of the fracture line. The group 1, which included 9 elbows, had a Milch type 1 injury, and the group 2, which included 10 elbows, had a Milch type 2 injury. Evaluations were performed with the use of radiographic examination, clinical assessment, and the calculation of the Broberg and Mori score. All patients were divided into two groups based on radiologic appearances of the non-union. While the group 1 patients had a small fragment of the lateral condyle, as well as a rounded radial head and concave capitulum resulting from a Milch type 1 injury, and the group 2 patients had a large fragment of the lateral condyle and almost normal radiocapitular relationship as a result of a Milch type 2 injury. In group 1, 8 of the 9 patients had ulnar nerve dysfunction, 6 patients complained of elbow pain, and 5 reported apprehension due to subjective instability. In group 2, 1 patient had pain after sports and working, 2 had apprehension due to subjective instability, and 8 had ulnar nerve dysfunction. The average carrying angle was 23 degrees in group 1 and 18 degrees in group 2. There was a tendency for carrying angle in group 1 to be larger than that in the group 2. In the two groups, there was a total of 16 cases of tardy ulnar nerve palsy. However, there wasn't any significant association between increase in the carrying angle and the development of ulnar nerve palsy. The tardy ulnar nerve palsy was a major symptom in both groups. It was concluded that the tardy ulnar nerve palsy may not appear until several years after the initial injury. Pain and restricted range of motion was seen mostly in group 1 patients, and in both groups, the range of motion tended to become more limited with passing time. It was concluded that group 1 non-unions consistently led to pain, instability, loss of function, tardy ulnar nerve palsy, and they should be treated as soon as possible after injury, preferably before skeletal maturity. The next study we are reviewing is the incidence, risk factors, and outcomes of avascular necrosis occurring after humeral lateral condyle fractures in children. And the study was published in Journal of Pediatric Orthopaedics in 2019. And this study aims to look at the incidence of avascular necrosis following the treatment of lateral humeral condyle fractures in children and to identify the potential risk factors which are responsible for this complication. The fractures were classified according to the Weiss classification, and variables like timing of surgery, open versus closed management, type of fixation, as well as radiographic evidence of avascular necrosis were studied. Avascular necrosis was diagnosed based on plain radiographs with progressive lucency or initial sclerosis followed by progressive lucency of the involved area with or without subchondral fracture or collapse. Stiffness was defined as loss of extension more than 30 degrees or flexion less than 130 degrees, 2 months after the fracture union. Union was considered established when bridging callus was visible across at least 75% of the fracture site in both anterior, posterior, and lateral planes. There were 500 patients available for final analysis. The incidence of avascular necrosis in this group study was 1.4%, representing 2 out of 178, that is 1.1%, as a result of type 2 fractures. and 5 out of 168, which is 3%, in the type 3 fractures. So the average time of diagnosis of avascular necrosis was 18 weeks, and all cases of avascular necrosis occurred following open reduction percutaneous spinning, and the presence of a type 3 fracture statistically correlated with higher incidence of avascular necrosis. Well, all patients regained full range of motion except one patient who lacked terminal extension and flexion compared to the contralateral elbow. 5 patients were asymptomatic, while 2 patients had mild and inconsistent pain. There were no patients with evidence of cubitus varus, valgus, or fishtail deformity. At final follow-up, all cases of AVN displayed radiographic resolution, and all cases of stiffness had resolved with physical therapy, and all malunions had healed with less than 2 millimeters of lateral migration and did not affect the final outcome. The risk stratification for avascular necrosis determined by the study was high energy injuries which needed open reduction. Both these were likely to increase risk of soft tissue stripping and compromise the local blood flow. But the next study we're looking at is growth arrest of capitalorophysis after displaced lateral condyle fractures in children, published in Journal of Pediatric Orthopaedics in 2012. The study was conducted at the Cincinnati Children's Hospital Medical Center in Ohio in United States of America. And the purpose of this study was to provide radiographic evidence of premature capitular growth arrest following lateral condyle humeral fractures and to substantiate it by CT imaging. 3 patients with Milch type 2 and Jacob 3 fracture were studied. All fractures had an open reduction and fixation with K-wires, and the average follow-up of these children was 6 years. The radiographs were evaluated for any growth disturbance, including premature capitular metaphyseal fusion, lateral spur formation, changes in humeroulnar angles, and fishtail deformities. While contralateral elbow radiographs were utilized for comparison whenever they were available. Of the 3 patients studied, 2 had increase in the carrying angle, 1 had fishtail deformity, 1 had normal carrying angle and small spur, 1 had restriction of elbow extension, progressive elbow pain, and mechanical symptoms like locking and catching. Growth arrest was evident on an average 1.2 years to 3.6 years from surgery. A review of literature was also done with regards to growth arrest following lateral humeral condyle fractures. And the importance of the study was really to highlight the fact that even after union has been achieved, observation is required as growth arrest may manifest later and produce angular deformation as well as pain and mechanical symptoms. But the last study being reviewed is the fishtail deformity, a delayed complication of distal humeral fractures in children. It has been published in Pediatric Radiology in 2014. And the study analyzes 7 children with fishtail deformity of the lower end of the humerus. The purpose of the study was to describe imaging features of post-traumatic fishtail deformity and discuss the pathophysiology of this condition. The etiology was varied. 5 children had supracondylar humeral fractures, 1 had medial condyle fracture, and 1 had a lateral humeral condyle fracture. Average age of these children was 10.6 years. Symptoms appeared 2 to 4 years after the injury. Characteristic radiographic abnormality of a concave defect secondary to underdeveloped lateral trochlear ossification center was noted in all the cases. Concave defect extended to the growth plate in all cases, and no normal growth plate was seen at the fishtail deformity. Well, additional findings were joint space narrowing, cartilage loss, subchondral cystic changes, osteophytes which were seen in 4 children, volar subluxation and hypertrophy of the radial head was seen in 3 children, proximal migration of the ulna was seen in 2, and post-traumatic synovitis was seen in 1 case. But the differential diagnosis was also discussed, which was normal pre-ossification center, mimicking an ischemic or inflammatory change as seen on MRI, idiopathic osteonecrosis, osteochondral dissecans, and epiphyseal dysplasia. The prerequisite was that these were considered in the absence of prior distal humeral fractures. But the review of literature regarding vascular supply to lower end of the humerus has been also done, which shows that the blood supply of the lateral aspect of the medial crista, the trochlear groove or apex, is particularly vulnerable to injury and predisposes to this condition. The children with minimal symptoms are treated conservatively with observation, while in some instances, debridement with removal of loose bodies, capsulotomy, epiphysiodesis, osteotomy, or ulnar nerve transposition may be required. Well, this brings us to the end of this review. Thank you very much for listening, and bye-bye.